Good evening, everyone. Welcome back to yet another episode of Diabetes Dialogues, an initiative by Voice of Healthcare towards diabetes awareness and health. Today, we have a very special guest with us. Please welcome Dr. A. Sharda, consultant, endocrinologist, and diabetologist at Manipal Hospital, Millers Road. Thank you for joining, Dr. Sharda. How are you?
Namaste. Very well by God's grace, sir.
Thank you. Thank you. So, our topic of the day for this discussion is going to be how to reduce the risk of diabetes complications beyond good diabetes control. So, let's start the discussion, Dr. Sharda. Yeah. So,
So,
to start with, to set the tone of this discussion, please tell to our audience about what is diabetes. To the layman, what is diabetes? We hear sugar, high sugar. Please explain, according to yourself, what is diabetes and some common signs and symptoms that we see when a person is diagnosed with diabetes. Please.
so the thing is, diabetes is always thought of as a sugar disease, although it is not a sugar disease alone. It affects lot of things, and there are lot of complications which can occur during the course of life when we live with diabetes. So, if the fasting sugar is more than 126 and the 2 hours after food is more than 200, it is termed as diabetes. So, type 1 is what happens to children and some older adults, and that is very less common and it is autoimmune. The large type of diabetes in the large masses which we are seeing, which has become an epidemic all over the world, and China, India, and US all are leading this in that order, is the type 2 diabetes, which is due to insulin resistance. That means insulin is the hormone which is produced by the pancreas, especially the beta cells in there. And if that is not working well, the body is not able to utilize or use the glucose for fuel. This leads to high sugar and lot of symptoms like dry mouth, thirst, frequent urination, nocturnal urination, and feeling tired, losing weight. And sometimes patients do come with complications like foot cellulitis, that is, some swelling and redness or wound in the feet, or they may come with fungal infections in their private parts, or non healing of wounds which have occurred due to other causes like that.
Mhm.
And some people can present with like a stroke or a heart attack, and a routine test done in the emergency room, to their surprise, reveals that they have sugar. Having said all these symptoms, there are 50% of people living with diabetes who do not have any symptoms. So we are talking about type 2 diabetes only henceforth. And
Mhm.
that is the reason people who live in China, India, US, where the prevalence of type 2 diabetes is high, should have routine checkups for blood sugar to
Right.
detect diabetes and diagnose it in the asymptomatic stage, to prevent them from coming with complications much later.
Right. Thank you. Thank you, Dr. Sharda, for setting the tone of this conversation and very, very vividly explaining the symptoms and the complications associated. While we are talking and creating awareness on diabetes, I'd like to speak with you about early detection. Very rightly that you said we are just talking about. So please tell our audience about the importance that early detection holds and the overall treatment life that we see for a patient. How do you feel that it basically jots everything there? Please.
See, early detection over the age of 30, all Indians with or without history of diabetes in their family, that is their parents, grandparents, maternal uncles, aunts, or paternal uncles, aunts, any one of them, if they have diabetes or even if they don't have diabetes, all should undergo a blood glucose evaluation in the form of fasting and 2 hours after food, or HbA1c. The screening techniques are much argued upon, which is the easiest, which is the best. It all depends on what is the available resources, whether we are doing a population screening or individual screening. If the patient or a person wants to know whether they have diabetes or not, they can easily go for the all the three tests. So that is what we are talking about here, and not a population screening or a public health screening. So checking is important. Urine sugar is no longer in the picture. we check only blood glucose levels, checking with the glucometer, because when parents have diabetes, children have this tendency, when they check for their parents, they'll check for themselves also.
Yes.
Although it is not a bad idea, never ever a glucometer reading, a machine reading done at home, is used for diagnosis. It is used for monitoring known
Hmm.
diabetic patient. So this should be confirmed in the lab, and then only the person is known to have diabetes. The other important thing Dr. Nishant asked me is the what should we do after we have detected it early. The most important thing is the patient or the person with diabetes is in shock whenever they have found that they have diabetes, because they would have heard that you this is a long term disorder, that they can have certain complications, and they are in fear, they are in rejection, they are in shock. They don't accept and deal with this problem. That is why they need to see a whole diabetes team who
Hmm.
can have a diabetes educator, a diabetes counselor, a nutritionist, and also a doctor. Because although the doctors do counsel, the patient is always thinking the doctor doesn't understand what they are going through. To
Right.
them, they are just another patient. So that's not true. And we do spend a lot of time with them, especially when they first detect that they have diabetes. And the other thing is, the studies which have been done show that if you treat the diabetes aggressively and well during the first 10 years of diabetes, their chances of having complications after that, later on in life, after 15 years, 20
Hmm.
years of diabetes, is much lesser than people who neglected their diabetes in the first few years of diabetes. In India, people think, Ayo, just now I got diabetes. I should not take medicine. I should
Hmm.
not go for treatment. I should try this. I should try that. And it is never ever that the treatment or tablets for diabetes is in lieu of lifestyle management, which includes a good diet, a healthy diet,
Right.
a balanced diet, and of course, physical activity, as is okay for that patient, because everybody has different levels and capacities to do physical fitness. So
Right.
whatever that person at that age can do, 30 minutes of walking also for 5 days a week goes a long way. But if they can swim for an hour or do yoga for an hour and supplement it with the walking 6,000 to 8,000 steps, very well, because the younger you are, the more fit you are and the better you do. So
Right.
these are the very important myths that we should not postpone the treatment of diabetes thinking it will become a habit. Patients will come and tell me, Doctor, I will get a habit for the
Hmm.
drugs. They may
Right.
not work later. In
Hmm.
fact, it is the other way around. You treat it aggressively in the first few years of diabetes, you reap much more benefits. This part is called metabolic memory. The body is supposed to remain and retain the memory of well controlled sugar for the first few years and still have less complications like heart attack, stroke, etc., much later in the life with diabetes.
Very, very nicely summed up, Dr. Sharda. Thank you. So, in the conversation, we have already discussed about complications. You gave a very good insight about how exercise plays an important role. I'd also like to understand what factors such as diet as well play a good role in the lifestyle factors that we have for diabetes, and what specific recommendations for diet and exercise do you recommend to your patients?
That's very, very important. See, basically, there are a lot of fat diets out there. Lot of, I think, money is made with quote unquote reversal of diabetes. And not that it doesn't happen, it happens. If anybody who is obese for their height is more than 15 kgs or 10 kgs obese for their height, if they lose that weight, 10 to 15 kgs, all of them will have a remission, not a reversal. They
Hmm.
do not have diabetes after having lost that weight. And then later, when with the years going by and the insulin secretion coming down with age, they may still have diabetes. So we have actually caused a remission. For a few years, we may be able to prevent and postpone the diabetes. So that is the importance, how much importance we have of lifestyle, that we can even reverse the pre-diabetes, borderline diabetes, that is the normal sugar fasting is less than 100, and the normal sugar after food is less than 140. Just now I told the normal fasting sugar, if it is more than 126, the fasting sugar, it is the diabetes. So anything between 100 and 125 fasting is pre-diabetes. Anything between 141 and 199, less than 200, is pre-diabetes by definition. So any one of them has either an abnormal fasting, which is not yet diabetes, or a borderline after food, which is not yet diabetes, are called pre-diabetes. These people, even if they lose about 5% of their weight, they will be able to do loads for their metabolism and reverse it and prevent and postpone diabetes at least for a few years. And how do we do this? We have to do nothing but good lifestyle. That is, see, weight, after all, is nothing but a balance of the intake in 24 hours and output in 24 hours. If we have chukka chapati and some sprout and little bit of vegetables in 2 3 cups, and we say this is all I eat, and in between we snack anything and everything we can find on the table, that is not diet.
Right.
You understood? Lot of people have this impression that if they eat chapati or ragi, that is the diet. These are the myths. It's not wrong to eat them, but that is not the only thing. After all, everything is a millet, whether it is wheat, whether it is ragi, jawar, or rice, they are all millet family as a plant. But the rice available nowadays everywhere is the highly polished white rice, so it has lost all its fiber. So what we recommend, that is why, is the parboiled rice or the red rice or brown rice. You have even got black rice. So basically, it keeps increasing the fiber content of that rice. Similar is the wheat, ragi, and all the other millets which are available. So everyone says, "Can I take millet, doctor?" And I'll be wondering, what else have they been eating for carb? It is some form of millet only. But I will
Right.
smile and say, yes, wholesome millets are good. They provide more fiber. So all this jowar and barn millet and finger millet, all are good. So you can use them as your carb in a small portion, but you should have at least 2 portions of vegetables in each meal. If you have 1 cup of rice, have 2 different types of vegetable cooked and raw, and have 1 portion of protein in each and every meal. Lot of people have only carbs for breakfast, and they have lot of salads for either the afternoon meal or the night meal. So it doesn't balance out. The sugar spikes after breakfast still remain there, and we all have lot of insulin resistance, especially in the morning hours. So after breakfast tends to be high for all of us, otherwise also. And hence, if you ask me, Dr. Nishant, what is the one thing I will request everyone to change in our country is the carb-based breakfast. We do not necessarily have proteins as cultural part of our breakfast. We all have to make an effort to add the salads or boiled vegetables and some form of protein. You can be a vegetarian. Even the non-vegetarians don't eat meat early in the morning in our country. So you can have eggs, or you can have sprouts or chana, which you have, soaked, and you can boil them if it is difficult to digest. Or you can have curd, you can have any milk product which is fermented, because milk by itself can cause lactose intolerance. And lot of people have seen that they have problems with gluten, which is what the wheat is about, the rava, the chapati, etc. If they have that problem, they should avoid it, because that causes inflammation. If they have a problem, that also can contribute to higher sugars. So you'll see lot of places recommending gluten-free diet cures diabetes, reverses diabetes. It's not for everyone. There are people who are sensitive to it, and there's nothing wrong in having a gluten-free diet. There are so many carbs available for us.
Right. Very, very rightfully summed up, Dr. Sharda. Now that we have spoken about the complications, about some common symptoms, and what kind of modifications can be done, let's talk for patients living with diabetes, and let's talk about medication adherence. So, while we are talking about lifestyle changes and diet and exercise, how crucial is medication adherence for individuals with diabetes in preventing the long term complications like you had mentioned in the early. And also I'd like to understand what some common challenges that patients face when it comes to medication every day according to your clinical practice and observation, please.
In last 30 years, it is very difficult to find that one patient who has never missed a medicine, because they need to take it like food. They need to take it every day,
Hmm.
sometimes twice a day or thrice a day, because many of these medications are not long acting. And even if you have long acting medicine, if you use it once, and it may be difficult to control the after food. So the medications which work for the after food raises of sugar, they are specifically to be taken with each meal. So it is very challenging for people to think that every time they think of food, they have to take a medications either before it or immediately after it. I
Yes.
do understand it makes them sad. Like I said, when you get diabetes, it is nothing to celebrate. You are in shock, you are in rejection, you do not want to have this problem, you want it to just go away. It is a nightmare. Like that, it is very challenging for people to keep thinking all their life. Suppose a person gets diagnosed in the mid 30s with diabetes, they are thinking for next 50, 60 years, I'm supposed to take medications every day of my life. So I do understand this. But if we do not take the medications, the downside is the life with it is full of very bad complications which can all be prevented, because we always need to weigh the risk benefit. It's just that we need to swallow a tablet which may not be psychologically happy for us to do. But if we were to do that and keep our sugars and other things normal, which I will tell in a minute, lot of complications and most of the complications of diabetes can be prevented. It is rather difficult to treat all of them because we still will have the stigma of that disease. Like suppose you have had a heart attack, there is a part of your heart which is damaged. But if you can prevent a heart attack, that's beautiful because your heart is fine. Same is true with the kidney or the eyes or the feet or the
Hmm.
brain, you know. So it is very, very important to understand the patient's point of view. And what is the solution? There are two things: to swallow a medicine, to check the sugars, to have healthy lifestyle with healthy balanced diet and regular exercise at least 5 days a week. And I expect around 60 to 80% adherence to diet. Rest of the time they can do whatever gadbad they want, but not
Hmm.
all together. I tell them do little gadbad once a week and keep feel happy. So if we were to do that, it really will prevent many, many complications. But the patient does not and cannot understand this, because they are many times not aware of the complications. And number two, they may not be aware that they can be prevented so easily. And like I said, if someone has long term diabetes, they have already damaged a part of their kidney or the heart, they have had a stroke, or they have had a amputation of their feet or whatever, that time being an aggressive doctor and treating the diabetes too harshly and too tightly can actually lead to more complications.
Hmm.
So it is important, like I said, to treat it well and aggressively in the beginning years of diabetes so that we have nice years, I will say, of retirement. And we are
Hmm.
not going to doctors all the time after 50, 60 years of our life. If we get
Right.
diagnosed between 30 and 40, 60 years admele, you want to just relax. And
Hmm.
instead, you are going to this doctor to that hospital to, just roaming around for treatment of the complications. So, what
Correct.
is the solution? We have both understood that this is what is at stake and this is how simply can be prevented. The solution is only one, and that is diabetes education. So, every doctor who treats diabetes cannot probably spend a lot of time with each patient saying the same thing. I understand that. So, my message to all the doctors out there is to have diabetes educators with them. You educate one person. They don't have to be doctor. They don't even have to do any medical degree. They just should be able to read and write and communicate with the patients. So a person who knows 4 5 languages if you live in a cosmopolitan city like Bangalore. So 4 5 languages or even 2 languages is fine, English and Kannada. And they are able, you educate them, you train them, and then you tell them to tell the patient. And coming from a non-doctor in non-medical terms, the patient will be able to understand. So diabetes education, especially in the beginning when they get the diabetes. Second, when they get any complication, when they get disturbed. Third, to reinforce learned behavior. Because all of us, suppose you tell me, you do this, madam, this is good for you. It need not be diabetes. I'll do it for a week, 10 days, 2 weeks. By a month, I'll go back, slowly drift back to what I was doing before. That is human nature and psychology.
Correct.
How do you expect these fellows to do it for 30, 40, 50, 60 years? So every 3 months to 4 months, they should touch base with the medical team, check the HbA1c once in 4 months. So they see the doctor, and they also see the diabetes educator. And the nutritionist also can be the diabetes educator. I always keep plenty of nutritionists who are trained in diabetes education also, so that they can answer the nutrition question and the diabetes questions to the patients. So
Patients.
this type of reinforcement and continued diabetes education is the key to adherence of medications, which you said, key to preventing complications and making patients check their sugars regularly, and prevent complications and live a good life. I have patients who have lived with 58 years of diabetes, 68 years of diabetes, and I tell them, sir, I don't have to do anything for you. You need to teach all of us how to live successfully with diabetes.
Very
It
rightfully
is
said.
possible.
Right. Hmm. Very rightfully said, Dr. Sharda. So while we were speaking, while you were just talking about monitoring, I'd like to understand two more things from you. First, the technology and the advancements that we are seeing in diabetes management, such as continuous glucose monitoring, and otherwise the parameters that we were discussing in the first questions about a glucometer and checking at the home. So how do you feel that regular monitoring is relevant, and how does it help prevent the long-term complications? And I'd also like to hear your views on these technological advancements, like such as CGM or any other that you'd like to speak of, please.
So there are too many questions in there. So we'll break it into
Of
two,
course,
three
yeah, please.
parts. Yeah. So the first thing is monitoring. The question is, who should monitor? The answer is very simple. According to me, anyone who can monitor should monitor. But what the guideline says is, the women who have diabetes and pregnancy 100% need to monitor. The people who have diabetes and they have received the kidney because their own kidney had failed, 100% they should monitor. All patients on insulin therapy, whether they are type 2 diabetes after 20 years, 15 years of diabetes, they are now on insulin, or they are type 1 diabetes who will always be on insulin. So people being treated on with insulin 100% need to monitor the sugars. And these special populations like kidney disease, patients who have received a kidney, pregnant patients, all children with diabetes. Why we need to monitor is the question. Because there is no ear pain for 250 sugar, or nose pain for 300 sugar, or some other symptom for 400 sugar. See, I have been treating diabetes for 31 years, and you ask me, I don't have diabetes as say, but you ask me what is my sugar, really, I cannot tell you because none of us can guess our sugar. It is
Obviously.
a very difficult thing to control something which we can't see. We can't see our sugar. So that is why we need to monitor. So you will ask me, apart from these people who are on insulin, who have some complication like kidney disease, heart disease, where we want to avoid the low sugar, who are on medications like sulfonylurea or other medications which can actually cause low sugar. Insulin can cause low sugar, hence you need to monitor. Sulfonylureas also can cause low sugar, hence you need to monitor. So why should other patients monitor is the thing I would like to answer, because it has a positive and negative reinforcement. Suppose they are doing a good job and they monitor and their sugars are in range, they get encouraged to continue the good job with their lifestyle, with their adherence to medicine and everything.
Very
And
right.
if they skip the medicine by chance, they have gone to a marriage, and people
Mm.
don't like to take their medicine in
Yes.
public. They want to be free when they are in marriage. So I have heard very funny excuses for not taking medicines. So one of them is, Doctor, I wanted to go to the marriage with a free mind. I said, Sir, if you take it in your job and take it privately somewhere, what will happen, sir? I have asked. Nobody will know. But they said, it's not about other people knowing, doctor. I want to feel free in my mind on that one day. And then suppose 2 hours later, they were to check their sugar and it is 350, which is always around 160. They will say, okay, it is better I take my tablet,
Should have
even
taken
if
the
I
medicine.
eat in the marriage. So it
Mm.
has negative and positive reinforcement of good behavior. So that
Mm.
is why even patients who are not on insulin or low sugar causing drugs like sulfonylurea, and they are not a special population like pregnant patients, children with diabetes, and kidney or heart patients, where low sugar has to be prevented and high sugar also should be prevented. These other patients also will benefit. They don't have to check every day, like twice a week they can check, once in a month if they're only on metformin. Otherwise, suddenly one day all their sugars will be normal. After 1 year, they'll come to see me, say hi to me, and their HbA1c will be like 10. And they will say, Doctor, I had no symptoms. I was just continuing the medicine you gave. And in Corona too, people are still coming to see me after 5 years, 6 years. I said, Sir, Corona itself didn't last for 3 years, sir. Why are you
Mm.
coming after 5 to 6 years? So they'll
Right.
come and they'll have very high sugars because it's an asymptomatic disease, like I have discussed before. That is the monitoring. Coming to technology, the continuous glucose monitoring has actually changed the way not only we treat the people with diabetes and monitoring, it has changed the way we are conducting the clinical trials. See,
Okay.
earlier, any trial of any drug for diabetes control will have fasting, PP, and a 7 point profile: before, after breakfast, before, after lunch, before, after dinner, and midnight, 3 a.m. or whatever. So, this is called a 7 point blood glucose profile. And you can have a HbA1c. So, fasting, PP, 7 point profile, and HbA1c. Only 4 points could be analyzed. With the advent of continuous glucose monitoring, which is done with a small coin like device, and once you put it, you can have a bath, you can swim, etc. No issues. You should not do sheer force. Suppose you have something here, you go and get with the car door or some door or something, or you wear a tight shirt or blouse and you take it out, there is sheer force. Then it
Mm.
removes it and the sensor is gone. Once you have removed it, you cannot reuse it. So I tell patients not to get a sheer force and lose the sensor, because it is 5,000 rupees and it gives you data for 15 days. It gives the trends. So this is called, when you see the minute to minute values and everything overnight, who can check so many times while you are sleeping? Every 15 minutes you get a reading. These are giving you overnight picture which we never had before, and
Mm.
minute readings which, like every 15-minute reading, which will give a trend for upward, downward. So if you're on an insulin pump, the insulin pump can talk to your continuous glucose monitoring device, and it will shut off the insulin before you actually have a low sugar. And now we have this semi-artificial pancreas, which will actually sense the sugar through the continuous glucose monitoring, and that is told to the pump. They talk to each other, and the insulin is increased if the sugars are continuously over a certain this one, which we have to set right. In one pump, I can say you set right for 120 as the always mean for the day, or 100
Mm.
as for this one, depending on the patient population. So this is the advent of technology. So what do we do with this information? There is a very important term called time in range. So that amount of time in range is what is now important. What amount of time in range should be there for the sugars in the 15 days you have checked every 24 hours, 80% of the time, 90% of the time, 70% of the time. And time below range is, suppose you set the time in range for a type 2 diabetes between 70 and 140 or 160. So time below range is the low sugar. There also there is a cutoff. Time below range from 70 to 54, time below range less than 54. This should be less than 1%, this should be less than 5%. So studies are also including. Similarly, you have time above range, 200 plus, 250 plus,
Hmm.
like. So the above range and below range, how much percent was there in these patients who were treated with this drug versus the placebo, etc. And even for regular treatment of patients, pregnant patients who are type 1, how much should be the time in range and what should be the cutoff? Pregnant patients with type 2 diabetes and this just gestational diabetes, children with diabetes, adults with diabetes. So we are now talking of a new term because of the advent of technology, that is the time in range, time below range, and time above range.
Right, right, right. And I think all of these parameters and all of these patches, continuous glucose monitoring, will help clinicians such as yourself prepare better treatment plans for people. And obviously, then in the longer picture, avoid the complications or maybe postpone the complications to an extent that is possible. Very, very rightfully, it's wonderful picking your brain, Dr. Sharda. So while we move towards the end of this discussion, I'd like to lastly speak a little bit about patient education and awareness. So you very rightfully pointed out in the starting that healthcare professionals should contribute to improving patient education and awareness about. I'd like to hear your thoughts about what you do as a part of your clinical practice to have patients aware and educate, and what techniques do you recommend to everyone who's watching, may be your peers or be it patients or the general populace. Please, Dr. Shada.
So, like I said, I spend a lot of time with the newly diagnosed young patient because, like I said, they are the ones who need all the tender love and care.
Hmm.
That I tell them nothing has happened. You just need to take a little bit of tablet and change your lifestyle. I always tell even the obese patients, there is no need to get worried. You may be 20, 30 kgs overweight. Just lose 5 to 10% of it, which is only 5, even if you're 100 kg. It is only 5 to 10 kgs, man. And nobody is 100 kgs most of the time. They are just getting near that like Sachin
Right.
Tendulkar. You understood? So we need to just lose about 5 to 10 kgs to get all the metabolic benefits. So we need to put it across very nicely and positively to the patient who is newly diagnosed. He is the most vulnerable. He is the one who is mostly going to default medications, default coming to the clinic. A, because he's in shock. B, because he's afraid. And he needs someone to talk and tell them that all is going to be well. So I tell them, do you want to see the person who has had 60 years of diabetes and doing well? Do you want to? All the children with type 1 diabetes and parents, I put them in a WhatsApp group, which is nothing to do with me, but all the other children are there and it is managed by one of them. So they talk to each other. Like I
Hmm.
said, many patients feel the doctors will not understand their plight. So you should, with this, advent of technology and WhatsApp and whatnot, we should have groups of people who have similar problems and let them talk if they choose to. You can offer, they can join any group. You should never, pressurize them to join any particular group. So giving support, giving understanding, giving time, when what the patient remembers, you ask someone, when did you have diabetes? They will never forget the day, the date, and the year, because that is something that changed their life
Yes.
forever. So that is how stressful it is for them. You ask them, when did you get married? Probably they may forget. But if you ask them, when did you get diabetes? They will never forget. I have not met a single patient who has not told me the time they got the diabetes, even after
Hmm.
20 years, 30 years. So we need to understand, empathize with the patient and talk to them, especially when they first get diagnosed. And at that time, I actually give them a small book we have all written for patients with diabetes. What is diabetes? What is type 2? What is type 1? What does healthy diet mean? That it is a healthy diet and a balanced diet for everyone. There is no diabetic diet. You can have lot of improvements. If you are obese, you can have different meal planning. You can skip a meal. You may do intermittent fasting. See, even the time restricted fasting and diet is equal to calorie restriction all through the day in the studies. So whoever can manage better with whatever regimen, we should individualize. The most important thing I would like to say, to all my colleagues and younger colleagues especially, we all know we have to individualize the treatment for diabetes. All the guidelines repeatedly, western people took many years to realize that they were doing guideline step by step. Now in the last decade they are telling that individualizing is important, and now all the guidelines in the last 5 years to 10 years have been saying that the risk management, that means you don't treat diabetes alone. You select certain drugs for people with heart problems with diabetes,
Hmm.
for people with kidney problems with diabetes, to prevent or halt the progression of kidney problems and the heart problems. And then, if you have people with diabetes and obesity, there are a couple of drugs which are much more effective in dealing with both the problems together, weight reduction as well as diabetes. If a person has low sugar with diabetes, you avoid certain drugs and promote certain drugs to prevent low sugar. So, like that, and if the person has some difficulty with economics, we are a country, India is not a country, it's a continent. We have people who are very rich and not so rich, and lot of people in between. We need as physician to cater to all of them. So the best treatment sometimes may be very expensive for the patient who has to look after his family, his children's education, marriage, everything. So he will not be able to afford it. For him also, we can go for the second best treatment. That is how we need to look at the treatment as physicians. And you can give them a handout about, like I said, about diabetes and how to prevent complications from coming to themselves by doing a health checkup once a year to screen for the complications. Like you do an ECG, treadmill, echo, maybe once a year, once in 2 years, do the lipids once a year. If they are having diabetes, do the HbA1c once in 4 months. All this I have nicely summarized in the end of the book. So book is good. 2, 3 languages you can keep. And if someone starts insulin, that is also a very stressful thing for the patient. They never forget the day they started the insulin, and the doctor who started, oh doctor, you started me on insulin, they'll never forgive you. So, and they will never say that thank you doctor, you prevented all the complications. They will be angry with you. It doesn't matter, but you should give them a handout how to carry the insulin if they are traveling. Otherwise they will stop during the travel. How can
Yes.
you say that the patient who is on insulin will never travel? Even if he doesn't tell you, you have to proactively tell, sir, when you travel, this is the guideline, and give him a single page handout in the language he understands. Next, how to store the insulin, where to store, and how frequently to change the needles, and how to check the expiry date. Simple things. One patient used to remove all the strips from the dabba and keep
Hmm.
it in the glucometer pouch. I don't know why. And and he used to keep the double also in the pouch. Why he used to remove, I don't know. And he used to always say his sugars at home are normal, 85, 120. Whenever patients say funny things like that, and when I check them, it is all very high. The HbA1c is 9, and they are telling, no, my sugars are only 85 and 120 after food. So I will tell them, no problem, sir. You bring your glucometer, you bring your insulin, you bring your medicine. Either they have changed the medicine or stopped one of them inadvertently, or they are not taking the insulin properly, or their glucometer, either a strip has expired, or battery
Hmm.
is not working, or they have exposed the strips. So you will find one of these problems. So these are the nuances. We need to spend time. We have to be systematic in our approach to treating patients with diabetes. Definitely with empathy.
Right. Thank you. Thank you, Dr. Sharda. Very, very nicely summed up and a wonderful conversation around diabetes. Now, before we end this panel, one last key take home message that you'd like to give to all the viewers who engaged, please.
So, like I said, diabetes is like, the Buddha story. There was a lady who went with a 5-year-old son who to Buddha saying, if you are God, if you are Buddha, make my child come back to life. So Buddha told her, apparently, this is a story. So I have not witnessed it, I have heard it. So he told her to go to any house in which there has been no death and bring some mustard seeds. And she could not do it. And in the end, she understood that this is part of life. Like that, in India, you tell me one household, one family which does not have someone with diabetes. either the grandfather, grandmother, uncle, aunt, yourself, your parents, your brothers, sisters,
Mhm.
someone will have diabetes. So nothing is lost if you get diagnosed with diabetes. Take care, find a good doctor, especially with a team who has a nutritionist, they have educators, be in touch with other people who have diabetes. And another thing I would like to point out, people in India are very secretive. They will never tell they have diabetes. So if they
Mm.
go somewhere to someone's house, they will never ask for sugarless tea or coffee
Great.
because you, they will come to know that I have diabetes. Anta. I have
Great.
patients who have completely broken all those things in very high places. And because of them, everyone else is following suit. You understood? Celebrities, big posts, very big judges, very big
Mhm.
ministers, they have broken all this, social stigma. We all should live freely. What if we have diabetes? That should be the this one. Go and achieve everything, enjoy everything, and have good life, even if you have diabetes. All the best.
Thank you. Thank you, Dr. Shada. It was lovely speaking with you. And thank you for taking your time out, stepping up with Voice of Healthcare in our diabetes dialogues and speaking about awareness and everything. So we thank you. Have a good day.
Thank you, sir.